A very good morning to respected judges and to all present here. I am Dr. Anirban Sorcer, PG Resident, Department of Pediatrics, IMS Some Hospital. My topic of presentation is antibiotic abuse and its consequences. So let us begin with a quote of Sir Alexander Fleming, who said that, "When I woke up just after dawn on 28th of September 1928, I did not plan to revolutionize all of medicine by discovering the first antibiotic or antibacterial, but that is what I exactly did." You can see in the background Alexander Fleming working on his microscope. We do not know what the world would have been if he had not discovered the first antibiotic, penicillin. So these are the contents of my presentation. So let us begin with the introduction. Now, what is antibiotic abuse? It refers to the use of antibiotics when not needed, right antibiotic but wrong dose, or prolonged use of antibiotics, or a broad spectrum antibiotic when it's not needed. Now, a survey conducted by the Indian Academy of Pediatrics suggested that 35% of pediatricians expressed a severe need, while 11% of pediatricians actually needed they had a moderate need of prescribing antibiotics as per the parental request. So it is a very alarming situation that we need to address. And another thing is that many a time clinicians prescribe antibiotics just because the patient party is satisfied by the prescription, and also he also avoids the journey of arriving to a diagnosis prior to giving an antibiotic. So what does this abuse of antibiotic lead to? Misuse of antibiotics contributes to the growing problem of antimicrobial resistance. Now, antimicrobial resistance leads to infections caused by resistant microbes, which have a prolonged illness and have a greater cause of death. Increased number of infected people in the community, thus the general population is at the risk of contracting a resistant strain of microorganisms. Now, antimicrobial resistance. As per the data published in the Indian Journal of Pediatrics, it is estimated that antimicrobial resistance will lead to 10 million deaths annually worldwide against 0.5 million annual deaths in the current era. And WHO AMR data suggests that it is directly responsible for 1.27 million person deaths, and it is a contributory factor for 4.97 million deaths. Now, what are the mechanisms of antimicrobial resistance? Inactivating enzymes, as in case of beta-lactamase producing antimicrobials, which render the penicillins and cephalosporins group of antibiotics ineffective. Target modifications, such as modification of the penicillin binding proteins, drug efflux, which is an important cause of antimicrobial resistance in Pseudomonas, or reduced drug entry by porin channel modifications, which is an important case in case of independent resistance in Pseudomonas. Now, the 30% rule of antibiotic prescription. 30% of all hospitalized patients at a given point of time receive antibiotics. 30% of those receiving have been prescribed inappropriately. 30% of all surgical prophylaxis is inappropriate. 30% of hospital pharmacy costs are due to antimicrobial use, and thus 10 to 30% of antimicrobial costs can be saved by antimicrobial stalwartship. Now, what are superbugs? This irrational and abusive use of antibiotics compounded with poor infection control measures are the driving force for global increase in superbug infections. Now, these are having multiple mutations, exhibit high levels of resistance. Gram-negative superbugs include the multi-drug resistant Acinetobacter baumannii or carbopilamanes producing Klebsiella. The gram-positive include vancomycin resistant Staphylococcus aureus with MIC more than 16 mcg per ml. Now, in order to counter this, we need to have a rational antibiotic prescription protocol. We need to do proper reasoning prior to prescription of antibiotic drugs, right dose, right route, and right duration, because it lies upon us to use antibiotics properly. Academically, the clinician must be updated regarding these decisions. Training of the mind of the clinicians, not only the clinicians but also its subordinate juniors in the form of PG residents, parents, pharmacists alike. Proper instruction needs to be given to the patient, and organism search needs to be done if required in the form of cultures. Noting down the diagnosis, having a proper antibiotic policy in place, taking into consideration the local sensitivity patterns as well as the ethical considerations as well as the economic conditions of the patient. So rationally is a mnemonic we can remember for the same. Now, what are the different modalities of antibiotic stewardship? The 4 Ds, that is right drug, dose, interval, duration. Prospective audit with intervention and feedback. Formulary restriction or pre-authorization prior to prescription. Switch from parenteral to oral therapy when required. Streamlining or de-escalating, proper infection control, appropriate use of antibiotic, microbial investigation if required, and other strategies like antibiotic cycling. Now, what is the conclusion we draw from the presentation? We should hit the following proper sequence of history, investigation, treatment, and we should ensure that we do not get infected with human irrationality virus that is born out of habit, ignorance, and varying factors that lead us to disregard antibiotic resistance while prescribing antibiotics. So think before you eat. Right drug, right bug, right time, right dose, right duration can help us towards battling this epidemic of antibiotic resistance. And I hope my presentation will be helping in that regard. Thank you, everyone.
Dr. Anirban